Assalamu alaikum. Hello everyone. My name is Leen Alhadlaq. I'm a second-year medical student, and this video will discuss the final two lectures of inflammation, which are chronic inflammation and systemic effects of inflammation. And the second lecture will be discussing the repair process. Now, the goal of this presentation is for you to have a focused, clear understanding of what distinguishes each lecture, such that you can build your own knowledge around it as you get to study it later on. My resources for the slides were the Robbins textbook and the 2020 KSU lecture slides. I would like to believe that these slides are easier to follow, but please keep in mind that I've deleted some portions and added some from the resources I used. Now we can get started. So the objectives of the first lecture is to define chronic inflammation with emphasis on the causes, nature of the inflammatory response, the cells involved, and tissue changes. And the second objective is to describe the systemic manifestations of inflammation and their general physiology, which are fever, leukocyte, lift shift, acute phase reactants, and we'll go into them in detail. Now, before we start, I'll go over these keywords quickly. Now, chronic means occurring again and again for a long time. So it can be persistent, but the key term is for a long time. TB is a chronic disease known in Arabic as sul. Malaise is the feeling of debility or lack of health. Anorexia is loss of appetite, and it's important to note that there's a difference between anorexia and anorexia nervosa. That is more of a mental illness. This is generally just loss of appetite. Opsonins are proteins that bind to foreign particles that help to facilitate phagocytosis. Atherosclerosis is the buildup of fats in the wall of arteries. Cytokines are small proteins used in cell signaling. Degranulation is the process that releases molecules from secretory vesicles. It usually happens from, they're usually released from mast cells. And a pyrogen is any substance which produces fever. Now we'll start with chronic inflammation. So to understand the general picture, inflammation in general, as discussed in the previous three lectures, is a protective response that involves host cells, blood vessels, and proteins, and other mediators. The main aim of inflammation is to eliminate the initial cause of injury and the necrotic cells resulting from it. And finally, to initiate repair after all of the inflammation process is over. So despite this, inflammation can cause harm by injuring normal tissues. And if the injury is so severe, destruction can dominate the inflammatory reaction, such as in prolonged inflammation or in some autoimmune reactions. Now, we discussed that in acute inflammation, if there is healthy inflammation, we can end with resolution and the cell is back to normal, there's homeostasis. However, if it fails to resolve, it can either lead to chronic inflammation or into scarring, which and the end. Now, if the initial stimulus doesn't directly cause acute inflammation, it can cause chronic inflammation if it's so severe, as I just said. So in the chronic inflammation, there's excessive repair and inflammation at the same time, and failure to resolve results in chronic inflammatory disease. So just generally speaking, the goal of the inflammatory reaction is to bring leukocytes, plasma protein, normally circulating in the body to the site of action. And it's usually controlled and limited. However, if, as I just said, just to repeat, if the acute inflammation does not resolve, by eliminating the exudate and the necrotic cells and restoring the normal tissue, it can either transition into chronic inflammation or extensive destruction that results in scarring. So this is just the general picture, just to keep in mind as we go on. Before we define chronic inflammation, it's important to note that there are 5 steps in any inflammatory reaction. So if we go just back slightly, so first there's an initiating stimulus, then there's recruitment of leukocytes, removal of the agent, this is the 3rd step. The 4th step is regulation of the response, and 5 is resolution. So usually in chronic inflammation, the problem is in the removal of the agent. So just keep this in mind before we go into the definition. So if we define chronic inflammation, it's a prolonged inflammatory response that involves a change in the type of cells present at the site of inflammation. So it's characterized by simultaneous destruction and repair. This is very high yield to know of the tissues by the inflammatory process. It's also very important to know that it's slow evolving, so it can take weeks to months, and it can result in fibrosis. So it's slow evolving, unlike acute inflammation, which can resolve within days sometimes. This takes weeks to months, and fibrosis, we're going to discuss this later on, but it's very characteristic of chronic inflammation. So if we're going to go over the causes of chronic inflammation, so there's a long reaction where destruction and repair occur, where inflammation and destruction occur simultaneously. So what causes this type of inflammation? Now, there are multiple causes. One is persistent infections by microbes that are difficult to eradicate. A very important example is TB. It can elicit a delayed type hypersensitivity reaction, which you're probably going to go over in immunology, that is mediated by T lymphocytes. Another example is Treponema pallidum. It causes syphilis. It's also very difficult to eradicate, and certain strains of viruses and fungi. Another cause of chronic inflammation is hypersensitivity diseases, so any immune-mediated inflammatory diseases or hypersensitivities like rheumatoid arthritis and inflammatory bowel disease, psoriasis. All of these are examples. However, I think the most prominent example is bronchial asthma. So in bronchial asthma, it's considered a hypersensitivity reaction that results in chronic inflammation. So over time, there is remodeling of your airways in the lungs, remodeling of your airways, so in the bronchi, and this is one form of chronic inflammation. The third cause is prolonged exposure to toxic agents. Now, there are two types. There's either non-degradable exogenous materials or endogenous materials. So an exogenous material would be like inhaled silica, which causes silicosis. And an endogenous material would be cholesterol crystals, which can build up in your arteries and cause atherosclerosis, which is تصلب الشرايين. Now, if we want to go over the morphological features of chronic inflammation, it's what distinguishes it from acute inflammation. These are the things we find histologically. So, one, there is an infiltrate of mononuclear cells. Unlike acute inflammation, which is characterized by vascular changes, edema, and neutrophilic infiltrate, chronic inflammation is characterized by mononuclear infiltrate, so not neutrophils. Although they are present to some degree, however, they do not dominate. There's also tissue destruction, as we discussed earlier, induced by the inflammatory cells themselves. And finally, there's repair involving new vessel proliferation, which is called angiogenesis. It's the formation of new vessels. We're going to go over it in the repair lecture, and fibrosis, which we're going to discuss also later on. So we just said that there are some distinguishing cells that are present in chronic inflammation. So we're going to go over them. The types of cells are macrophages, lymphocytes, plasma cells, eosinophils, and mast cells. And we're going to go over each one separately. Now, the most prominent are macrophages. They are the dominant cells in chronic inflammation. They are derived from circulating monocytes from the blood. And they're normally found diffusely scattered in connective tissues. So they are resident in some tissues such as the liver, the spleen, central nervous system, and the lungs. And in each certain location, they have a specific name. So in the liver, for example, they're known as Kupffer cells. In the spleen and lymph nodes, they're known as sinus histiocytes. In the central nervous system, they're known as microglial cells. And in the lungs, they're known as alveolar macrophages. The main function of macrophages generally is they constitute the mononuclear phagocytosis system or the reticuloendothelial system. So they mainly engulf pathogens. This is their main purpose. So if we want to go over what happens exactly, so monocytes under the influence of adhesion molecules and chemokines migrate to the site of injury within 24 to 48 hours from the onset of inflammation. So at this point, chronic inflammation has begun. And this picture is just to illustrate. So bone marrow is where the hematopoietic stem cells are formed. They evolve and become blood monocytes that circulate the body. However, when they're activated and when they leave the systemic circulation, as soon as they leave systemic circulation and they're found in the connective tissue and the extracellular matrix, they become activated macrophages. Now, the activated macrophages are bigger and they have a longer lifespan, and this is what differentiates them from monocytes. If we wanted to go over the resident macrophages, they don't come from this simple pathway. So they come from embryogenesis. There's a progenitor yolk sac, and then they form that immediately. They become resident macrophages, which are these. So as I said briefly, they are the dominant cells of chronic inflammation, and their role is mainly to ingest. One is to ingest and eliminate microbes and dead tissue. So this is when we imagine macrophages. This is the task we imagine them completing. Another very important role they have is secreting mediators of inflammation, such as cytokines, notably tumor necrosis factor, interleukin-1, and other chemokines. The third role is to display antigens to T lymphocytes and response to signals from them. Now, this picture might look slightly intimidating, but please bear with me, it's pretty simple. This is the activated macrophage. It has multiple tasks. It can either, 1, as I just said, engulf microbes and dead tissues. 2, it can display antigens to T lymphocytes, so right here in this process. So the activated macrophages stimulates the T lymphocytes. Now, and it can 3, release tumor necrosis factor and interleukin-1, which helps the inflammatory process in general and induces more leukocyte recruitment. Now, as you can see, this looks pretty much like a cycle. There's somewhat of a bidirectional stimulation. And we're going to go over this again later on. But just to simply understand it, lymphocytes and macrophages interact in a bidirectional way, as I just said. So macrophages stimulate T lymphocytes, and T lymphocytes, by the role, stimulate macrophages by interferon gamma. We're going to go over this again, but I just want you to understand that it's somewhat of a cycle. They stimulate each other. And this is all I need to take from here, from this picture. It might look intimidating, but this is all that matters to me at this point. Activated macrophages stimulate T lymphocytes, release tumor necrosis factor, interleukin-1, and themselves can phagocytose. Now we're going to go over the action of lymphocytes slightly later on. Now, if we want to go over how macrophages are activated, they're not all activated in the same way. So they do start as monocytes, however, they can be activated in by 2 different pathways. One is the classically activated macrophage. Now again, this picture might look slightly intimidating. It's very simple. I'm going to go over it. So classically activated macrophages are stimulated by interferon gamma, which is mainly secreted by T cells. Just in this picture, I'm going to go back. So it's released by T cells. This is a very important cytokine for you to know. We're going to go over it many more times. So if you don't memorize it now, it's fine. But it's the most prominent one, and it's very important for you to know. So if we take it as an example, so a monocyte is activated by interferon gamma, it becomes a classically activated macrophage. Now this macrophage is called an M1. These macrophages are important in host defense against microbes and many inflammatory actions and might be activated by many stimuli, so not necessarily interferon gamma, which is released by sensitized T cells. They can also be activated by bacterial endotoxins. Now, if you've taken the gram-positive and gram-negative lecture, you'll know that endotoxins are released by gram-negative bacteria. So this is the classically activated macrophages. So they have microbicidal actions and they generally stimulate inflammation. So they contribute to it. Now, the alternatively activated macrophages are anti-inflammatory. So they do the complete opposite. They function mainly in tissue repair. So they are both necessary as tissue repair often follows inflammation. So it has anti-inflammatory effects and helps in wound repair and fibrosis. So it's anti-inflammatory. And the general cytokines that stimulate are interleukin 13, interleukin 4. We're going to go over them in the repair lecture. So the main thing I need to take out from the slide is that there are two pathways of activation, and that the classical M1 pathway contributes to inflammation, and that the alternative M2 pathway is anti-inflammatory. Again, this picture just to demonstrate again. So these are monocytes adhering, immigrating, diapedesis. They become tissue macrophages activated by interferon gamma or by endotoxins. They become activated macrophages. They can either cause tissue injury or generally inflammation or tissue injury that accompanies inflammation. So these are all actions they have. They can release nitric oxide, coagulation factors, or they can contribute to fibrosis, which is healing generally. And this is the M2 alternative pathway. This is the classical pathway. Now, lymphocytes. Inflammation generally is considered an innate response, so innate immunity. However, chronic inflammation has elements of adaptive immunity that is mediated by lymphocytes. This will be discussed thoroughly in your immunology lecture, so I'm not going to go into this in detail. However, the T cells and B cells mediate the adaptive immunity of the chronic inflammation. So T cells and B cells migrate using some adhesion molecules that recruit lymphocytes, the same pathway. It's just similar recruitment. They migrate and to site of affected into inflammation site, tissues affected by chronic inflammation. And their role again is to mediate adaptive immunity, the adaptive element of chronic inflammation, which provides specific defense against infectious pathogens. So innate immunity, just to briefly mention it, innate immunity is non-specific and adaptive immunity is more specific. So chronic inflammation has elements of this. So if we want to compare T lymphocytes versus B lymphocytes, the images might be terrifying. They're simple, don't worry. They're just here to demonstrate and to give you a general picture. Don't worry about them. So T lymphocytes. In response to stimuli, mainly cytokines, they can be released from macrophages, for example, present at the site of antigen recognition. So there's an antigen-presenting cell, which can be a macrophage, a dendritic cell. A naive CD4 T cell may differentiate into populations of effector cells. So a CD4 T cell is naive. It's non-specific in any way. However, after stimulation, it can evolve into one of three, either Th1 cells, Th2 cells, or Th17 cells. Each one of these produces a distinct set of cytokines and have different function, a specific function. So to go over these three specialized cells briefly, Th1, for example, secretes interferon gamma. This interferon gamma, as we discussed before, is what mainly stimulates what? Macrophages. And what pathway? The classical pathway. So they are responsible for activating macrophages, meaning if we go over this, so they are responsible for activating macrophages. Macrophages are the dominant cells in chronic inflammation, so we can conclude that Th1 cells are very prominent in chronic inflammation. An example of sites where they can be present is in TB, for example. And we're going to go over TB and granulomas briefly later on, but just keep this in mind for when that comes. Th2 cells secrete interleukin 4, interleukin 5, interleukin 13, which activate B cells and recruit eosinophils, both of which can be seen in asthma reactions, where IgE predominates. So IgE is an immunoglobulin or an antibody that's released by B cells. So if B cells are activated by Th2 cells, so it's safe to conclude that they are prominent in these reactions. They also recruit eosinophils. So eosinophils are also predominant in asthma reactions. So Th2 are prominent in these cases. Now, Th17 is not really that important in my own point of view, but just for you to know, it secretes chemokines that recruit neutrophils and monocytes. And as I said before, neutrophils are present in chronic inflammation, just not to the same extent as they were in acute inflammation. So, and Th1 and Th17 cells are usually present in bacterial, viral, autoimmune reactions, while Th2 are in allergic reactions such as asthma, as I just mentioned, and they can be present in parasitic infections. I want you to keep this in mind when we go over eosinophils. You'll understand why later on, but just keep that in mind. So just to quickly go over them, Th1, TB, activate macrophages. TB is an example. Th2, activate B cells, recruit eosinophils. Asthma is an example. Now, B lymphocytes, they function in humoral immunity. Now, there are naive/immature B lymphocytes. They recognize antigens and under the influence of Th cells, which help in stimulating them, B cells get activated and proliferate and differentiate into antibody-secreting plasma cells. So plasma cells are the mature form of B lymphocytes. So this picture is slightly terrifying. I'm not going to lie to you. However, just for you to understand, naive B cell differentiation, they become either they become either memory B cells or plasma secreting plasma cells that secrete antibodies. So either one of these, and each one is an example, but this is more of an immunology point, not a pathology point. It's just very important for you to know that B cells are present in chronic inflammation and that they mature into plasma cells. Again, this is, I think, more clear. So naive B cell, helper T cell stimulates B cell, becomes activated, results in either memory B cells or plasma cells. I think it's clear. I think this image is clear. Now, plasma cells. Plasma cells are, as I just mentioned, mature B cells. They are the common cells in chronic inflammation. They are common cells in chronic inflammation. They are the primary source of antibodies. So they are mainly what secretes antibodies, which are important for neutralizing antigens and clearing foreign antigens as well. So antibodies generally can neutralize the pathogens, the antigens on the surface of the pathogen. They can sometimes facilitate phagocytosis by acting as opsonins. As for the morphology of plasma cells, they have an eccentric nucleus, so it's not in the center. You can see it's eccentric on the sides, and not necessarily circular, so it's kind of oval and it differs. It shows a cartwheel clock face pattern, so this kind of pattern somewhat, and there's a perinuclear halo, so this is a perinuclear halo. It resembles a cartwheel, as you can see here. Now, the morphology is very important for you to know. So if someone describes to you a perinuclear halo, a cartwheel, or clock face kind of image, you have to keep in mind plasma cells. Next slide. Mast cells. Mast cells are present in both acute and chronic inflammation. So they are the first cells to release contents and induce inflammation. They're widely distributed in connective tissue, so they are normally present. They don't need to be recruited, unlike macrophages and lymphocytes. They express on their surface the receptor that binds to the Fc portion of IgE. An Fc portion is this portion of an immunoglobulin or antibody. So this is the receptor on the surface of the mast cell where antibodies can bind, and this binding is what stimulates degranulation. So if we take IgE, for example, IgE sensitized mast cells, so they've seen IgE before, release histamine, which causes vascular changes and allergic reaction. Now, if you remember when we mentioned the Th2 cells and how they stimulate eosinophils and B cells, if IgE is the immunoglobulin released by B cells, if we take asthma as an example, IgE is released, it binds to the mast cells, it releases histamine, and it gives you the systemic manifestations of asthma. So with histamine, proteases, all of these. This is the general picture. We're going to go over it in the respiratory block in detail, but this is all I need you to understand now, is that they have a receptor, antibodies bind here, then they degranulate. Release histamine and products of arachidonic acid oxidation. It's very simple. Now, eosinophils. Eosinophils are abundant in immune reactions mediated by IgE, as I just mentioned. IgE is the immunoglobulin. So they are present in allergic reactions such as asthma and in parasitic infections. Allergic reactions such as asthma, so as I said before, there's Th2, eosinophils, these are all usually correlated together, and in parasitic infections. So it's very important for you. If there's one thing I need to take out from this slide, it's for you to correlate eosinophils with allergic reactions and parasitic infections. If you only understand this, then it's great. So just to quickly describe them, they respond to chemotactic agents derived largely from mast cells, as we just mentioned. IgE, release histamine, release other cytokines. And their granules contain major basic protein. So if you can see, it's not very clear. However, if you zoom in, you can see they're kind of granular. So these granules contain major basic protein. These are toxic to parasites, hence why they are widely present in parasitic infections. They lead to the lysis of mammalian epithelial cells in some cases as well. Now the patterns of chronic inflammation. There can either be a non-specific pattern, so there's no distinguishing characteristic in the histological view, so, or it can be granulomatous. Yes, okay. So a non-specific chronic inflammation would be caused by foreign materials, for example, such as silica and asbestos, and in some autoimmune diseases such as autoimmune thyroiditis. As you can see, there is no specific structure to the inflammation. You can see many lymphocytes and macrophages, however, there is no clear structure. A granulomatous inflammation is one in which modified macrophages called epithelioid cells accumulate in clusters and surround lymphocytes. Why do they surround lymphocytes? Because lymphocytes are what activate macrophages, if you remember what we mentioned before. So a lymphocyte releases interferon gamma that stimulates macrophages. Now, if the inflammation is persistent, if we take an example, the example of TB, where a granuloma is almost always present, in TB, the T cells stimulate macrophages. However, there is a persistent infection. They're unable to eradicate the causative organism. So in that case, more macrophages accumulate over time, and it results in one large rim. Of course, the image is cut from here, so you can see this rim, it continues. of macrophages and that surround lymphocytes. And in some cases, these macrophages, these epithelioid cells, might join and form one huge multinucleated giant cell called a Langerhans giant cell. And it generally looks like this. It's kind of like a horseshoe appearance. So this is a Langerhans giant cell and not Langerhans. Keep this in mind because Langerhans are antigen-presenting cells. You're going to take an immunology probably. However, they're not related to this lecture at all. I just want you to distinguish the spelling between these two. So Langerhans giant cell, multinucleated giant cells present in granulomas. How do they form? From the joining of multiple macrophages or epithelioid cells. And you have an entire lecture on granulomas, so this is just to give you a brief introduction to it. So finally, if you want to compare the acute and chronic inflammation, the causative agent is due to pathogens or injured tissues. In chronic inflammation, it's persistent infection, some autoimmune reactions, and some toxic, potentially toxic, inhaled endogenous or exogenous materials. The major cells in acute inflammation are neutrophils. In chronic inflammation, mononuclear cells such as macrophages, some lymphocytes, plasma cells, and others. The primary mediators in acute inflammation, as I said before, acute inflammation is characterized by edema and vascular changes, so there are vasoactive amines that cause vasodilation, for example. However, in chronic inflammation, interferon gamma, for example, is very prominent because it's what stimulates or activates macrophages. The onset is immediate. Onset means it begins suddenly in acute inflammation. However, in chronic, it's delayed. It can either be a type of delayed type hypersensitivity. Acute inflammation lasts a few days. Chronic inflammation lasts up to many months. Acute inflammation can either result in resolution, abscess formation, or it can lead to chronic inflammation if it persists. Chronic inflammation can result in either tissue destruction, so it does not heal, or fibrosis. And if we want to go over how it starts, the stimulating agent or the injurious stimuli itself can either result in acute inflammation directly or in chronic inflammation directly. So chronic inflammation doesn't always begin from acute inflammation. It can begin directly. However, in some cases, it does begin. An inflammatory response begins as an acute reaction that is followed up by chronic inflammation. So that was the first lecture. Not the first lecture, the first part of the first lecture. This part is pretty simple, so I'm going to go over it quickly. So the systemic manifestations of inflammation are present in both acute and chronic inflammation, so just keep that in mind. Acute phase reaction is the term we use generally for any systemic affective manifestation. So all of what I'm going to mention till the end of this lecture is an acute phase reaction, which is a systemic manifestation of inflammation. So what are the acute phase reactions? 1, fever. Exogenous pyrogens such as bacterial products, so these are products that induce fever, or they can be endogenous pyrogens such as interleukin-1 and tumor necrosis factor that are released throughout the inflammatory reaction. So these cytokines are the most important mediators because they can cause high blood pressure, high heart rate, and they can later stimulate prostaglandin E2. Now, prostaglandin E2 is very important because it changes the set point of the hypothalamus and raises the temperature of the body. I did not go over it in detail here. However, it's very simple. Another reaction that might happen is malaise. Malaise is when you're tired, and anorexia is loss of appetite. So these are the general manifestations. Now, in the bone marrow, so this is also an acute phase reaction. There can be leukocytosis, Leukocytosis means an increase in the number of leukocytes. It can either be neutrophilia, lymphocytosis, or eosinophilia. Now, the specific type is determined by the causative organism. So neutrophilia is usually caused by bacterial infections. Lymphocytosis is caused by viral infections. This is very important for you to know. You're going to take it in other lectures as well, but just keep in mind neutrophilia is caused by bacterial infections. Lymphocytosis is caused by viral infections. Now, if I want you to guess, what does eosinophilia represent? If you said parasitic infection, then that's correct. And sometimes when there is a huge demand for leukocytes, the body is not able to release completely mature cells. So what happens is that there's a shift to the left. So this is the normal maturation way. However, if the body is not able to produce all lymphocytes that are mature, some of them might be released immaturely, and this is called a shift to the left because we're going that way instead. So these are released as well, however, without completing the pathway. I think it's clear. In some cases, however, just to slightly mention this, in some cases there might be leukopenia, which is a drop in the number of leukocytes. Examples of cases that cause this are infections such as rickettsia and in some protozoa. So just keep that in mind. It's not always leukocytosis. It might be leukopenia. Acute phase proteins or reactants. So these are usually released by the liver. They are normally present in low concentrations, but increase following hepatic stimulation by interleukin 6. So interleukin 6 stimulates the liver, and the liver in its role releases acute phase proteins. So examples of these are CRP and CAA. We're going to discuss them. C-reactive protein and serum amyloid A. These bind to microbial cell wall and can act as opsonins to fix complements. They act as opsonins to help facilitate phagocytosis and fix complements, which can destruct the microbe or the pathogen. So if we want to go over them, I've deleted some of them, but these are the most important. So C-reactive proteins, or CRP, is a marker of acute inflammation and increased risk of myocardial infarction in patients with coronary artery disease. There's serum amyloid A, and then there's fibrinogen. So a rise in fibrinogen causes erythrocytes to stack and form a rouleau. So fibrinogen is what is present when platelets bind and stick to each other. So if there's an injury and there's a plug, fibrinogen is present. It helps in coagulation as well. So this rouleau, these blood cells in the presence of fibrinogen can sediment more rapidly than individual erythrocytes. So the blood cells clump together, and this sign is an indicator of inflammation. However, it's not specific at all. So it does not tell you what type of inflammation it is, and does not necessarily tell you how severe the inflammation is. So if we want to go over it slightly, so these are the columns where the blood is placed. I think you're going to take it in the physiology lecture as well. You're going to see it in the practical. So these are the erythrocytes normally. In the presence of fibrinogen, they stack above each other and they form a rouleau. So here are they, the normal blood in the tube. After 1 hour, for example, it sediments to this rate. Now, it's normal for the blood to sediment outside of the body. However, in the presence of inflammation, they sediment at a higher rate. So if they normally sediment until here, in inflammation, they go as far as here. And this is the end of the first lecture. We're going to go over the second lecture slightly.